Good afternoon, everybody. First of all, as General Secretary of the Manuel Giménez Abad Foundation, I will very briefly address you to introduce this seminar about health, psychology, and society after the COVID-19 pandemic. First of all, I would like to express my gratitude to the Embassy of Canada and to the Canadian Ambassador to Spain, Ms. Wendy Drukier, Professor of Law, not only for making this seminar possible, for her fruitful collaboration and also the cooperation we've been having in the recent times, for a long time with the embassy. Next year, we will be 20 years old. Our foundation will turn 20. And from the very beginning, we counted on the Embassy of Canada for organizing any events, any activities we intended to organize. So I extend my gratitude, my thanks to all the staff, also Marisa Canales, for organizing this event. We've been collaborating with her for a long time. So really, thanks, my sincere gratitude. And just wanted to start off with this. Of course, I extend my thanks to our speakers this afternoon and to Xavier Arbós. I won't say thanks because he's part of the foundation. He's one of us. No, really, I was just joking, of course. As always, thanks for your so important contributions. For our foundation, this epidemic has become a challenge. It's been a turning point in our activity, in our work. However, it's been a positive. I like to speak on a positive note because it made us work, act, and think differently. Differently in the sense that, well, we can anticipate about how we will have to work when the pandemic is finally finished. How we will be holding our events. And of course, we will be happy to greet our ambassador once all this is over. Hopefully this will be sooner than later. We will be more than happy to have you to visit the Al Jafaria building, this Arabic palace, Mudehar Palace, which is definitely worth visiting. Anyway, we are suffering the event, and this epidemic has been a catalyst for many changes, that were emerging, that were budding in a budding phase. On this occasion, we are going to tackle with a topic that appears on the press every day. It's having an increasing importance. The relationships between and the links between health, psychology, and our society. What our society will look like after the pandemic. All the experts are pointing out and warning about the impacts of the pandemic, both collectively and individually, personally. How we will come out from this epidemic, from this crisis, each and every one of us. In my foundation, I've seen positive impacts. However, such a brutal crisis will undoubtedly have consequences, serious consequences in economic terms, in terms of healthcare, mental health, and it will even affect our collective mood. So this is just everything I wanted to say. This is another of the series of events we're holding to analyze how the pandemic is affecting our society in general terms and more specifically, and that's why it was so important to make a benchmark and a comparative have a comparative view with the help of our Canadian friends, having a look at what happens in a country, Canada, that has been a reference, a benchmark for us for a long time. I give the floor to Mr. Xavier Alborg, to our ambassador, to the Canadian ambassador. She will be in charge of presenting this seminar from the embassy. Thank you so much, Jose. It's a real pleasure to be with all of you today, this afternoon, to speak about this very important topic. And of course, I'm not an expert in these matters, so I won't take much time from the time allotted to the very experts, to the speakers. So, first of all, I would like to thank the Manuel Giménez Foundation and to the Canadian Foundation for organizing this important seminar. I'm sure you are all aware it is absolutely necessary considering the current circumstances. My special gratitude to Xavier Arbós and José Tudela, who will share the opening table, and to the Spanish panelists, the different
panelists, Catherine, Régis, and Emmanuel Bernheim. Ça fait plaisir de vous voir sur l'écran. Yo llegué a Madrid a mediados de diciembre en unas circunstancias.
I arrived in Madrid in mid-December under serious circumstances that prevented me to meet personally the closest collaborators to the Canadian Embassy to Spain. That is why this is an excellent occasion to introduce myself virtually for the moment and to be at your disposal to jointly work in priorities and concerns that Spain and Canada share. Mental health in pandemic times is one of the topics that make apparent the vulnerabilities of our society. So from the onset of the pandemic, Canadian researchers followed the consequences of COVID on mental health of citizens, on Canadian citizens, and they try to provide figures and facts to the phenomenon: isolation, loss of jobs, concerns for children, the family members, the elderly, combined with the continuous stress. We've been suffering this situation for a whole year, unbelievable. Just now, already a year. All those factors contribute to the increase in the ratio of pleasure, stress, and anxiety, about 25% in the Canadian society since last summer. Among the most affected classes are youngsters between 18 and 24, teleworkers, healthcare workers. There are many of us. In a study carried out by the Canadian Mental Health Association, they came to the conclusion that 40% of Canadians state that their health has deteriorated since last March. On the other hand, the general suicide prevention system increased demand in 200% since the onset of the pandemic. These data suggest that mental health of Canadians has suffered a lot due to the pandemic, with a lot of pressure on primary care providers. That is why the First Minister and the Ministry for Health have tackled measures and will work jointly with the provincial governments that have powers in the healthcare system, so as to create strategies and to increase the situation of our citizens. The First Minister announced last May an investment of 240 million Canadian dollars to develop, launch, and disseminate different measures to improve mental health of the Canadian citizens. In the case of mental health, this investment will be devoted to improve access to mental health in a safe and and a healthy way to reduce pressure over the healthcare systems, with the goal of delving deeper on that need. From the 3rd to 9th of May this year, we will hold a week devoted to mental health, organized by the Canadian Mental Health Association with the support of the federal government. Well, what should I say? Very briefly, I will give you some examples of what the largest provinces in Canada are doing. In Quebec, they devote $31 million to increase access to psychosocial services of mental health, so that every person that apply for it have direct access. On the other hand, we will reinforce proximity services to expand social and psychological visits and consults for Ontario, the most populated province. $147 million complementary to the program. This provincial program is devoted to provide a mental health service provision, high quality provision. These supplementary funds will be devoted to immediately expand access to mental health services. However, we still face huge challenges in Canada, and as always, systems take time to adapt to the new reality, to the new circumstances. Our experts, Professor Régis and Bernheim, will delve deeper in the access area to healthcare services in mental health and the footprint about COVID and lessons to be learned, at least in Canada, after the pandemic. I'm sure, well, hope they can be relevant to all of you. It would be interesting to compare the Canadian perspective to that of Spanish. Without further ado, I give the floor back to the organizers to, well, kick off with these highly interesting presentations we will have with the cases of both countries. I hope to get to know you physically, face to face, during my main mandate here in Spain. That's all from my part, and merci beaucoup.
Xavier.
Javier, you have the floor. Xavier Arbós, our chairperson. Can you hear me, Xavier? Now his mic is unmuted, finally. Well, that's all. Thanks for your invitation. I would like to thank you for giving me the chance, the opportunity to share this panel with professors that I've known for a long time. I'm proud to say that they are my friends, and very happy to get to know our Canadian experts. Needless to say, the topic we will be tackling is highly important. Some housekeeping remarks, technical observations for speakers, please. You have 20 minutes for each of the presentations, so please do not get angry with me if when you are about to finish your 20 minutes, I warn you that you have to finish. For the rest of you, for the members of the audience, you can choose either Spanish or English. You can just choose it from the globe icon on the lower bar, on the toolbar in Zoom. You can select the language you choose, either the floor or your own mother tongue. Finally, a warning: at the end, we will have about half an hour for the Q&A round. So these questions, please write down your questions on the chat, right? And we will read them out and translate them when needed. So I would like to give the floor to Professor Catherine Régis. She's a professor research professor in Canada in law and healthcare policies. She's specialized in healthcare law, and I will directly give the floor to Professor Régis. Thank you.
Buenas tardes.
Hello.
Good afternoon.
Is it my turn? I don't speak Spanish at all, so I just want to make sure that it's time for me to speak. Yeah, okay. So first of all, I'm going to try to share my screen. Oh, can you all see it now? Yes, okay, wonderful. So first of all, I really want to say thank you to the Foundation for inviting me. I'm so excited to be here today. I think you mentioned that we should be careful about the time and really stick to our 20 minutes. So if I go a bit overboard, please send me a message through the chat so I can make sure that I wrap up rapidly. So I was asked to talk a little bit about the impact of COVID-19 on the healthcare systems across Canada, and also to give a bit of background on the constitutional division of powers in Canada, how it works ultimately. So this is what I'm going to do. It's a broad mandate, but I'm going to give an overarching picture, and then we can discuss further on some aspect during the question time. So what I'm going to do more specifically, just to give some general remarks and to start on COVID-19, the Constitution, and also the government's capacity to act during the pandemic. And then I'm going to give some more specific remarks on the digital innovation footprint on the Canadian healthcare systems. So about the general remarks, and I know there's ongoing translation, so I'm going to try to speak a bit slower, but again, just give me a sign if it's too fast. So just general information about COVID-19 in Canada. So the total count of cases right now is about 855,000 cases that we have. And just keep in mind that we are about 38 million Canadians. The two most affected provinces are Ontario and Quebec, and they have about 300 cases each. They are the most populated provinces, so ultimately that makes sense. Also, there's 1% of the Canadian population are long-term care residents, yet more than 80% of COVID deaths are affecting this group. So that's a very important concerns for sure. And I know it's shared across the world as well, but that's something that was kind of a failure on our side for sure. There are different measures to control the spread of the virus from provinces to provinces. So there's a lot of variation depending on the urgency and the importance of the virus for each provinces. We have some lockdowns, there's a closing of schools, stores, public spaces. There's also mandatory wearing of masks and financial incentives to really help people to stay home, for instance, and help them with the financial burden of the pandemic. Traveling is not totally banned, but they are a strong discourage measure and disincentivizing measures as well, such as the need to stay at hotels, for quarantines if you travel, the need to have a negative test in order to come back to the country if you have traveled. There's also restrictions for visitors, a restriction for non-essential traveling, for instance, between Canada and the US. And also there are some restrictions for traveling from one province to another or even among cities. As for the constitutional part of the COVID-19 crisis, so health is a shared legislative competency in Canada. So the two levels of governments really interact during this pandemic, and sometimes it is a challenge to really coordinate this shared competency. But just as a broad picture, The approval of vaccine is a federal competency. The management of healthcare workforce is something that provinces and territories are responsible for. The management of the healthcare systems is something that is delegated to provinces and territories. Public health is a more complicated legislative competencies. Both level of governments can intervene, and it's not totally clear which one should do what in what cases, but as a broad ballpark, when the public health issue can cross borders, can be something that impact on other provinces, it should be a matter for the federal government. But then if it's really local, provincial government are responsible for public health matters, and the control of borders is a federal competency. I think a lot of lessons can be certainly drawn from this pandemic, and it's not over. But one thing that I think that this pandemic really illustrates is the importance at the end of the day of having universal access to healthcare, really having this system where everybody can have access to treatments and ultimately vaccines and other, very important healthcare services during the pandemic. Just a reminder, there's no constitutional right to health or healthcare in Canada. That's something that is surprising sometimes to hear, because we are kind of well known for our healthcare system. And that's something is also surprising to Canadians themselves. But we don't have this constitutional right, but at the end of the day, every province has implemented a public health care system. And this system mostly covers hospital and medical care services, and the access is guaranteed based on needs and not the ability to pay. So that's what we call universal access. But this system is really focused on medical services and hospital services. So there are other services that kind of are less protected, and you see a lot of variation across the country. And among these services that are less protected is the long-term care services. And this is certainly something that is related to across Canada, the bad cases and the really poor management of long-term care services that we saw during the pandemic. Just also the Supreme Court of Canada said there's no positive obligation for the government to offer public healthcare services, as I mentioned at the beginning, because it's not guaranteed under the Constitution. But yet the court said if the governments decide to implement these services, this public healthcare system, they have to do so while respecting the Canadian Charter, the value of the Canadian Charters. And among the key rights that kind of influence healthcare is Section 7 and Section 15 of the Constitution, which is the right to life, liberty, and security, and also the equality right, which is Section 15. So I know that we are, in the emergency right now, governments are trying to do their best in managing the healthcare system and the pandemic. But I think that after the midst of all of that, we're going to see some court challenges, and we already have some, and they will probably be mostly based on these two sections of the charter. Other general remarks regarding government's capacity to act during the pandemic. Regarding the management capacities, not the constitutional capacities, but we see during the pandemic an increased intervention of the executive power. I think it's shared among other countries. For instance, in Quebec, we have the Public Health Act, which allows the government to declare a public health emergency situation, which Quebec has done for the first time during the pandemic, but first time in its history more broadly. So this power gives the government a lot of liberty to take some actions, but it has to do so within the framework of the law, and the law allows the government to declare this emergency situation for 10 days and without the approval of the parliament. But if he goes beyond 10 days, he has to do so with the approbation of what we call l'Assemblée nationale, which is the parliament. When there's such a declaration of power, the government can do a lot using its executive powers, such as closing education institutions, public spaces, order a mandatory vaccination, restrict areas on Quebec territory, and ultimately also take all necessary measures to protect the health of the population. So it's a kind of a broad power. Yet the pandemic occurred in a context, and I'm very curious to hear about what's going on in Spain regarding that, but in a context where the reduction of the state has been occurring for some time. So it's mostly based on ideological posture of less state is better, right? Let's delegate more to the private market dynamics, although we still have a strong state intervention, but we've seen over the years a diminishing of that intervention. And also it was really central that mentality to the actual government we have in Quebec. And the previous government, which was a liberal government, had made a lot of significant cuts in public health spending. So what about timing, right? Reducing that spending that was not already really high, but was diminished strongly before the current government. So public health has been neglected in healthcare investment for a long time, which is about 1.5 to 4% of provincial healthcare budgets ultimately. So I think another lesson that a fact that we can recognize now is that the pandemic has highlighted the fragilities of minimalist states and strict managerial vision of the conduct of public affairs. And also, we're not there yet, but I really think we should move towards recognizing to recognize the contribution of state workers and the necessity to have a diversity of expertise within the government. Regarding constitutional capacity, so during a pandemic like that, but in general, broader context as well, the government, there's some right protected in the charter, but the government, if it's not protected in all cases, if the government infringes on a right, it has to kind of proceed with a test to make sure that this infringement is justifiable in a democratic society. And this is what we call the Oakes test, which is a very fundamental constitutional test. So if the government infringe on this right, it has to respond to these 4 questions, which is, was the response related to a real and urgent need in a free and democratic society? I think this question will be responded quite positively in the context of COVID. It will be easy to prove that it was an urgent need, right? Also, is there a rational link between the objective and the government measure? So the two, are they like, do they make sense together? And again, I think this test will be quite easy to succeed for the government, but then the other 2 questions might be more difficult depending on the context. So was the measure adopted by the government a minimal infringement of right? So if there's another option that impose a lesser infringe on a lesser way on rights, the government should have chosen that way. And also the 4th question of the test is it proportionate to the objective? Like, we shouldn't use a hammer, right, to kill a bug. So is it proportionated? And when we're going to proceed with this test, because I'm pretty sure we're going to see a lot of this going in court ultimately about the government's action during COVID-19, useful facts or evidence that's going to be used during the constitutional challenge are what kind of options were available to the government at the time? Did he choose the best option considering that test? And also, do we have any international comparison of what our countries have chosen? And is that something that we can really use to evaluate the proportionality, for instance, of what the government did in Canada? And ultimately, I also think that the proportionate use of restrictive means during the pandemic is quite revelatory of the relationship democratic governments have with the rule of law. So now moving to the specific remarks, I thought it would be interesting to talk about the digital innovation footprint that the COVID-19 crisis had on our healthcare and healthcare systems. So we had epidemic before. This is an old problem, but to that extent, maybe that's debatable. But what we have different now is new technological means, right? So did we use these means and what does it mean for the healthcare system? So it's a question that I find interesting. So there was a mondial effect of this really excitement at the beginning about how could we use these technological means to really help managing the pandemic. And during the first 3 months, there were 140 digital solutions in 50 countries that we at the beginning, and then we have obviously more now. It was mostly for virus detection and infection tracing or follow-ups. These digital innovation solutions were for different stakeholders and different objectives. Some of them were to help with confinement measures, detection of virus infection, also to provide information to the population in a new ways, self-evaluation of symptoms, management of resources, teleconsultations, and so on. So I think against all odds, what the digital wave illustrated is that we can have more agility, at least from a Canadian perspective, in our healthcare system and more capacity to adapt to a reality than we thought it was possible in our sometimes very stuck in a status quo healthcare system. What we saw also is that the highly technical and innovative digital options and the artificial intelligence, for instance, remain difficult to implement. There's more space for modest digital innovation in the healthcare system. Also, what the COVID-19 revealed is that it's always been there, but I think it's kind of increased with the current crisis. Is there a strong tension between innovation and regulation? And the innovators often ask the question whether the law is a problem in this context, and that really stopped the innovative movement. But then when you take this from a legal perspective, you see the importance of really having this framework that regulation to make sure that it develops in a responsible way. So we saw some legal changes during the pandemic to really adapt to this digital opportunity and challenges for sure, to increase our capacity to really use these tools. And for instance, during the early stages of the pandemic, we made sure that the law was more adapted and agile to ensure that telecommunication services were considered as an insured services under the healthcare system. So it was paid now by to healthcare professionals, and there were no fees for patients or citizens wanted to access these services. So this is something very big for us because we are very old-fashioned people regarding access to healthcare. So you need to see your healthcare provider face to face, otherwise it was kind of considered outside the healthcare system. So now having access to your healthcare professional on the screen and being able to talk to that person is kind of amazing for us, I have to say. Also, we adapted some other modalities to make sure that was easier to access to. I'm not sure about time right now. Let me see. Do we still have time? I'm good? Okay. just very quickly on the type of digital innovation that we saw during the COVID-19. So they were for, as I mentioned at the beginning, for different stakeholders, for patients or the populations. They were digital tools for self-assessments of symptoms to define what to do. For instance, should I take a screening test or stay home and be isolated? But in Quebec, at the beginning, it was kind of a slow start. We had to wait until August, for instance, to have access to this tool. There's also tools to ensure the transmission of information, to have access to your test results, for instance, if you were exposed to a case, also general information on COVID, and expected behavior that you should have depending on the level of risk or your city or areas and so on. So it was a specific challenge for Quebec at the beginning. When we implemented that digital option, it took 30 days to obtain a test result, so which doesn't really make sense when you think about it. But now it's really more efficient. With 24 hours, you will have your result. And there's a variety of tools that have been used. So website, mobile apps, targeted or general alerts, and even an Amber Alert. I don't know if you have that in Europe, but it's kind of a alert that use every digital means that you have, like your telephone, your screen, your TV, and everything stops, and the government send a message, be careful about that. But usually it's used for when kids are adoptions, but now it was used for the COVID-19. There's also options for clinicians. So we really increase, as I mentioned, the teleconsultation access, so from patient to professionals. We also have tools for remote monitoring of vital signs. The goal is to limit the interaction as much as possible from person to person. We increase the tele-expertise access as well, so from professional to professional. Electronic prescriptions. We also have algorithms to support the diagnosis of COVID-19 and target patients at risk of complications. So really the positive effect of all this terrible crisis is that it was a great accelerator of the telehealth, which is something you really needed during the pandemic. We will see after the pandemic whether we keep this or not. So for managers, there were a lot of tools also developed to optimize the planning and use of resources, especially human resources. So to avoid labor mobility,
Disculpe, profesora, tendría usted que...
I am sorry, Professor. You will have to finish very soon.
Okay, so I'm gonna, so just going to finish on the challenges. So we saw that there's a variable access, variable content, and variable recommendations that these tools provided. So that was kind of a challenge. It was not uniform across Canada for sure. Sometimes the recommendations were conflicting. So at the beginning, the federal tool and the Quebec tool did not make the same recommendation for the same clinical scenario. So 14 days compared to 10 days of isolation, for instance. Also, a lack of accountability and transparency regarding these tools. Or for teleconsultation in the country, there was a lack of transparency about the origin of the initiative, the business model, the participating professional, for instance. There was a mention that these tools that you were using, you were not sure of the business model, whether it was private or public, for instance. It was mentioned that professionals were authorized to practice in Canada, but it was impossible to verify that information. That's just an example of a issue. Tracing apps, everybody heard about that. I just want to mention that we hit kind of a roadblock with these tracing apps. I think the social acceptability of these apps was not there. So the efficacy of them at the end of the day were really low. In Quebec, in Canada, for instance, we chose to have voluntary app, and only 2% of the population chose to comply with it. So it's a very low rate, and at the end of the day, it's not very effective. So if you have any question about what we use, what kind of AI we use during COVID-19 crisis, I'm happy to answer that. I was the second part of my talk. Okay, I'm just going to conclude on that. So the law is central, but it is tested in very singular ways during the pandemic. So there's an unusual balance between the executive, legislative, and judiciary branches of power. And there's also an incidental tension between law and innovation that I don't think we're there yet. What kind of tension we want, what kind of balance we want. I think we're going to see some legal challenges for years to come about what we have done, what the government has done during the pandemic. It's going to be a lot of legal brain and intervention going on. And I think we also saw with the COVID-19 that there's opportunity for changes in our healthcare systems. We should try to keep the good after the crisis and get rid of the bad and the ugly of what we have done during that time. So ready to have learn some lessons from it. So thank you. Sorry if I use too much time. I get lost when I speak. And merci, gracias. Thank you very much.
Muchas gracias, profesora Régis. Ahora voy
Thank you very much, Professor Régis. Now I will give the floor to Professor Bernheim. She is a professor of psychiatric law. She is specialist in law practices in mental health. And undoubtedly, she will give us a very interesting vision. So whenever you want, Professor, you have the floor and you have 20 minutes.
Thank you. I will try to share my screen. I think you see it all, yeah. So first, I want to thank the Foundation for its invitation to talk about a subject I think is really important, of course, so which is mental health rights. So what I'm going to do today is that I'm going to talk about access to care and condition of hospitalization and the use of coercive measure in mental health in Canada. My point will be that the pandemic has not necessarily created new problem in mental health care, but has exacerbated problems that was already present in Canada and elsewhere, I think. So I'm gonna try to change the slide, but I don't know if it's working. Yeah, okay. So first, the mental health of Canadians has declined substantially since the beginning of the COVID-19 pandemic, and the situation has affected mostly people with pre-existing mental health problems and disabilities, people under 24, Indigenous people, and parents with children under 18. 68% of those with pre-existing mental health condition have reported high level of anxiety, worry, as well as stress, loneliness, sadness, and depression. And 10% of Canadians report having suicidal thoughts, and 4% report deliberately harming themselves. Hospitals report a significant increase in consultations of eating for problem of eating disorders. Canadians report using a variety of coping strategies, including the use of alcohol and drug and prescription medication. Deterioration in mental health have been associated with an increase in the use of psychotropic drugs and overdoses. And the situation has been defined as a crisis by Canadian police, as well as by educators and healthcare professionals. So what we are seeing is a vicious cycle in which mental health deteriorated as a result of the pandemic, which leads to an increase in the need for mental health services. However, at the same time, the difficulty to access care and services contributes to further deterioration in mental health. So these vicious cycles affect the most vulnerable people hardest, of course, because of their socioeconomic situation. So before the pandemic, healthcare, it was already said by Catherine, but healthcare was already underfunded and difficult to access. So as the result of a pandemic, the need for services has been higher, which worsened this pre-existing condition, of course. As soon as the state of emergency was declared, province closed psychiatric hospital beds, and professionals that were working in psychiatric hospitals were assigned to COVID-19 related services. So hospitalization is reserved for the most serious situation, and as we have seen, clinic consultation must be take place remotely, by telephone, or by Zoom. The lack of staff has resulted in fewer services being available in the public system. And the paradoxical effect of that is that patients have no choice but to turn to hospital and emergency. As a result, some hospitals have reported a 13% increase in psychiatric admission since the beginning of the pandemic. Another effect of the lack of services is the increase in call to the police regarding mental health issues. Since the beginning of the pandemic, several incidents have been reported during police intervention with people in crisis. And police services are calling for more resources for effective mental health intervention now. At the same time, requests for consultations increased by 10%, and crisis centers and community groups report receiving increasingly complex cases, which were normally dealt with by hospitals. In an attempt to meet these growing demands, cities and provinces have put in place online support services. These include, for example, telephone hotline services or online counseling services, but only 2% of Canadians say they use these services. It must be said that the most vulnerable people often have limited access not only to the internet, but also to the telephone. These include, for example, people who are homeless, people who live in a great economic precariousness, or people in rural areas. So the mental health system in Canada have been characterized by a physician-first approach in which psychiatrists, as opposed to other mental health professionals, are primarily responsible for everything. So the diagnosis and the treatment and the follow-up. The pandemic has exacerbated the problem caused by the physician-first approach, which has long negatively affected the accessibility of mental health services. Increased needs and worsening mental health problems have created pressure of primary care services that are unable to keep up with demand. Healthcare staff, nurses in particular, have experiencing burnout and compensation fatigue, and many are now on sick leaves or have left the profession in recent months. The range of services offered in the public healthcare system is limited. In particular, psychotherapy, which would help to treat several conditions, is almost inaccessible in the public healthcare system. In this context, the pandemic has accentuated pre-existing inequality that were existing before. Access to services is unequal to the extent that some services, such as psychotherapy, are accessible only or almost only for those who can afford them or who are insured. Because services are less available, people who cannot afford private services are sometimes left out. So we've seen that a lot of admission in hospitals have been taken place since the pandemic have started. But at the same time, hospitalization conditions have greatly deteriorated because of the staff shortages, but also because psychiatrist units were not designed to implement health measures such as distancing. As a result, there have been reports isolation lasting several days, in some cases several weeks, as well as bans on outings, visits, or calls, which have resulted in an inability to communicate with loved ones. The requirement to disinfect telephones each time they are used has made their use almost impossible on psychiatric unit hospitalization, but similar measures with similar problematic results have been applied in group homes. For some people with severe mental illness, as well as for seniors suffering from dementia and for homeless people, the application of sanitation procedures might be impractical. This has led to the use of measures such as involuntary hospitalization, admission, or other involuntary treatment to manage the pandemic risk. When these measures involve a judicial process, that process takes place remotely. The patients are in the hospital while lawyers and judges are at the courthouse. Several problems have been reported with these judicial processes. For example, since bailiffs cannot enter hospitals, it is difficult to notify hospitalized persons about court proceedings. Communication with lawyers is almost impossible without access to the telephone, and remote court appearances are generally perceived by defendants as less satisfactory than court in prisons. So the pandemic has not necessarily, as I said earlier, created new problems, but it has exacerbated existing problems that have long been documented in Canada, in fact, and elsewhere too. On the one hand, the lack of investment in mental health care over the year had led to insufficient or inadequate care provision and to the use of coercive measures. For example, the lack of staff to supervise visits or outings is one of the reasons that even hospital or group home grounds are not allowed to be used for outings or visits. Staff shortages also prevent the implementation of disinfection and distancing procedures. Lack of resources in the system also prevent the development of local services that would allow faster action in crisis situations for people not living in the proximity of a major hospital. In this context, it becomes to the responsibility of the police, who are not adequately trained, to intervene. On the other hand, the context of pressure on primary services exacerbates the consequences related to the prejudice already present in the healthcare system. For example, since the declaration of a state of emergency, some Quebec ministerial directives are based on the idea that people with mental illnesses cannot understand and implement health directives. These guidelines recommend in some cases the use of measures such as involuntary admissions or isolation. The scientific literature confirms that people with mental illnesses are less likely to obey and implement health measures as lockdown and isolation. However, there are 2 points of view on this issue. On the one hand, some authors have agreed that people with mental illness are likely to experience significant difficulties understanding and respecting anti-COVID measures. They recommend systematic isolation and mandatory vaccination of persons with severe mental disorders. But on the other hand, some authors have attributed these difficulties to the discrimination associated with mental illness in the health and social service system and the living conditions which make social distancing impossible, such as homelessness, no access to basic hygiene supplies, substance abuse, and the conditions in some housing units. According to these authors, it would be essential to provide adapted information to people with mental illness. It's also essential to facilitate the intervention of multidisciplinary teams and to include loved ones and family in mental health follow-up. So pretty much the contrary, that's what we have seen in Quebec. And coercive intervention should be used only at the least resort. So the pandemic highlights the fragility of rights in mental health. So that was a problem that was already present, but we see that we had some measure that can make sure that we can access rights and exercise them. But now that we are in that emergency situation, we see that it's really fragile, in fact. At first, care and services in the public system are difficult to access. They are offered mainly in hospital. They focus on the medical dimension of mental health, and we know that there's a lot of other way to intervene in that kind of situation. So this situation compromises directly the ability of people who do not have the financial resources to make choice about the type of care they want to receive and professionals they want to be treated by. Second, the hospital practice appears to be discriminatory in several respects. So during the pandemic, there have been a noticeable difference between the treatment of people with mental illness compared to both the general population and patients hospitalized for physical problems, including COVID-19. Those hospitalized in psychiatry were hospitalized longer and in more difficult conditions than those hospitalized in physical care. When the lockdown ended, nothing changed in psychiatric hospitals and group homes. Exceptional measures such as involuntary admission have been used for people with mental illness, but involuntary isolation have not been used so much for people without mental illness and who don't follow the anti-COVID measures. Third, the condition in which legal proceeding takes place make it difficult for defendants to exercise their right to counsel and their right to full and complete defense. So to finish, I'm gonna talk about what Samantha Hill, which is the president of the Ontario Medical Association, said in a press release. So she said, history tells us that the demand for mental health services will continue to grow in the years to come, and that demand will contribute to the pandemic deficit of care we have yet to address. So she said she was making a link between what we are living now and to the 1918 influenza pandemic. And she said that during this period, the need for the increase for services in mental health continue for at least 6 years after the virus has largely subsided. So we can expect now that the effect of the COVID-19 pandemic of mental health and on mental health, need for mental health care and services, and the impact on the provincial healthcare system in Canada might be felt for a long time to come, and that we have to that we have to think and to do something about that. Thank you.
Muchas gracias por su intervención. He olvidado.
Thank you for your intervention. I forgot to say that Professor Burnham belongs to the civil law section of the law college at the Ottawa University. I'm going to give the floor to Dr. Miquel Porta. He is the head of the clinical and molecular epidemiology of cancer at the Hospital del Mar in Barcelona. You have 20 minutes. Thank you. Thank you so much for your introduction, Xavier, Arbós, and to all the organizers of this very important session on health psychology and the society after the pandemic. I hope you find interesting the topics of my presentations. This is one of the key messages that I will unfold over the coming minutes. It is obvious we are facing a devastating crisis. Some people tend to undermine it. I sincerely hope we no longer have to face such an unmanageable crisis. to come out of so much death and ruin. And I hope you can see the slides correctly. We need that the civil society, the civil different mechanisms, institutions, etc., support governments and institutions, public health institutions acting within the healthcare system and also from outside the healthcare system. Later on, I will elaborate on that. The alternative political program to populism, the so-called Trumpist populism, is a more efficient state that promotes order, justice, efficiency, rationality, trust, and compassion. These are powerful, persuasive elements that are indispensable and also attractive. So this is my main response, the main proposal. Sorry, I couldn't read the chat. Please tell me if you want to communicate with me. Well, this is the question I ask. Are more and more citizens convinced about the supra-regional realities? For instance, the obsolescence of several state apparatus and several policies, not only in public health. Undoubtedly, we are facing new and old stresses, tensions between the individual and society, between laws, liberties, rights, economy, and health. But we have the obligation to look at them from a constructive point of view. We can find innovative ways of solving these problems. Public health institutions are important inherently, but they are also an example of a type of systemic and social institutions that are absolutely indispensable on any democracy. Do not consider them merely as healthcare provision institutions, and there are many similarities, common grounds with other social policies institutions. If we don't consider then that now, when will we consider that the pandemic make invisible the dramatic effects of having inefficient institutions and state mechanisms? I even dare say, before my friend Xavier and the other legal experts, we are also, all of us are aware, fully aware, that sometimes laws, regulations are inefficient. Maybe legal systems that do not pay enough attention to the effects, to the impacts that are not palliated or alleviated. So how can we overcome the inaction, the effects of that lack of action we've witnessed over the last year? We must reflect on the need to change the law, the regulations, so that we anticipate other future problems, serious problems, such as the current pandemic. I'm really concerned, not as an epidemiologist, but also as a mere citizen. We need to change the system, the law system. New regulations are needed. We need to face obvious truths. Immobilism is really bad. If we do not do anything, it will be terrible. The re-centralization is not desirable or unfeasible. It's not desirable, in my opinion. And this shows us that we can make progress towards a type of state, you can call it federal or not, that is kinder, more useful, and more just, because it will give a better response to the great problems facing society that are accelerating and getting more and more complex and more serious. Pandemic is showing it. How many people are clear about that? This is more obvious than any other time in history. Some other people, as I said, that tend to undermine the effects of the pandemic. As an expert in epidemiology, the pandemic is not the mere result of just adding up or multiplying little problems. The pandemic is much more than the sum of its and every one of the small problems. We have a supra-regional. I will restrict myself to the autonomies. You know that in Spain we are divided in autonomies or regions or sub-federal units. So the pandemic is more than the sum or even the multiplication of the problems. We somehow intuitively can, well, kind of grasp this dilemma. I give you a more simple idea. No region, no regional state can face such a problem of such a magnitude by itself. This is a powerful idea and mobilizes non-sectarian groups, social groups. But this discourse should be more present. As an epidemiologist, it seems to me that it's obvious that a region and autonomous communities defend only those things that affect them. They are really selfish. Some of them are really selfish and not willing to collaborate with their peers, with the other regions. Their obligation is to defend all of the citizens and the whole economy, and this irritates populist and sectarian populations.
I know this idea might seem provocative, but for me, this is very obvious, not now with the pandemic, but since many, many years ago. I think that each autonomous community should assume its responsibilities. And furthermore, I think it is very clear that each autonomous community is not doing well with a weak state. For example, we can think of the Interterritorial Council of Health. It is not working properly, and it happens the same with the Ministry of Health. It is very weak. So isn't the pandemic the most powerful reason that our generation, those who are younger than 19 years old, to appreciate and to act on these facts? I think the pandemic is the most powerful reason, but before it, we already had some powerful reasons to act. Well, and now I will devote some minutes to talk about what we understand about public health, because it is not the same as a public health system. Public health is everything that we do as society to promote, protect, and restore the health of people from inside the health system and from the outside. This is an existing reality, in part invisible, and also a political, cultural, and civic proposal in order to go further and somehow overcome the crisis that we are currently living. Public health is the health of the wholeness of society. Those are institutions, companies, and organizations that protect and promote the health. It is about public and private policies, laws, services, programs, everything that you can see here in this slide. This has an influence in health, and this is public health. That would be the summary. Those who impact in health, those institutions, companies, organizations, those products, policies on the elderly homes, this is public health, and the same about health, or for example, the social enterprises or the national health system. Everything is public health. Is that clear? So as I said in the beginning, public health is an example of an institution or companies or organizations that are essential in democracy. What is the serious problem? Well, for many years, many of these policies were invisible. The investment that we made in Spain and in other countries are very, very low. I imagine you will have seen the chaos with the systems of epidemiologic answer, or for example, making a follow-up of cases. these policies are essential for the economy, and the damage that they do for economy, these obsolete institutions, is very big because of these institutions that you can see here. And I am afraid that we are not learning hard enough about the need to invest in such systems, in epidemiology, for example. Everything I just said is part of what professionals and health professionals already know. You can see it here in the Dictionary of Epidemiology. Or in a more colloquial way, public health takes care daily of what we breathe, drink, and eat, how we work, move, and live together. And the pandemic has made very, very clear this statement. We never thought we would live something like this. For many years, we have created some models, like the one you can see here about the state of health. Here, we see many, many factors. For example, the earth crisis, the climate crisis. All of these factors for many years are part of these systems and factors that impact public health. And that's why public health is not a synonym of public health systems, because usually we are talking, when we talk about public health systems, is more on an individual basis. And here we include collective services, for example, vaccinations and vaccination campaigns, systems, the logistics. And here we exclude, when we talk about public health system, we exclude the policies and the services that are from the outside and that have an impact in health. That is part of public health system. And that's why public health system is not the same as public health. And having said this, I will devote some minutes to talk about mental health, because Professor Arbós asked me to do it, although I have to say I am not an expert. However, I would like to mention some important studies. The first thing was made on suicidal thoughts and behaviors in the Spanish adult general population. And this was made by the group of my colleague Alonso and other researchers. Here they worked with a representative sample of 3,500 people in June, and they made several telephone interviews. And the conclusions were that the prevalence and frequency at a given time for 30 days with suicidal thoughts was 4.5% in Spanish population. People with mental disorders during their lives or now had greater percentages of these numbers, and the risk was also bigger. In fact, the risk was multiplied 6 times in people who had these anxiety disorders, or maybe they already suffered from panic attacks. So in these cases, the suicidal thoughts and the risk was 6 times higher. And this was also bigger in people who lacked social support, or those who worried about their health, or those of their dearest people. In this other study, they focused on mental health impact in healthcare workers. This was made between May and September. And this was made among more than 9,000 people, and 28% notified depressive disorders, 20% anxiety disorders and panic attacks, 35% notified disorders that didn't allow them to live normally, and In these cases, the likelihood was 6 times higher among those who already had some disorders like anxiety, for example. Or it was multiplied and was 1.7 times higher among those who had to suffer from a lockdown. And finally, we see here another study, and here 1 in 7 Spanish healthcare workers screened positive for a disabled mental disorder. And finally, also among healthcare workers, from March to July, in more than 10 hospitals, they analyzed these suicidal thoughts. And here we can see very important conclusions. The prevalence, 8%, although there were only 6 who tried to commit suicide. And anyways, this makes very clear the importance to act and to prevent those pathologies. And now, during these last minutes, I will come back to the ideas that I mentioned in the beginning. This supra-autonomical dimension of the inter-autonomous collaboration, the need to strengthen the state government. I think this evidence that was already present before, I don't think they are leading to important actions on an institutional and government level. If we are not aware now of this interlinking on an autonomic level, I don't know when we will do this supra-autonomical reality, because Madrid, the head of state, doesn't have to be the one that makes all the calls. We need a supra-autonomical dimension that makes a better management. So we have to cooperate to positively intervene in these socio-economical fluxes. And also, it is highly needed that this cooperation and loyalty is based technically and politically promoted from more democratic, efficient, and fair institutions. State institutions are not the government from Madrid, because we tend to think that it is this state of Madrid, and we usually attack this vision. And state institutions cannot be from Madrid. Why? Because we have to be coherent with the local and global effects of these institutions. Secondly, because of the local and supra-autonomic effects. And thirdly, because we need supra-autonomic effects and systemic in order to control the pandemic. All of these might sound very theoretical, but you have to think of the National Health Center. It doesn't have to be from Madrid, from the government. It has to be a center for all of us, in which all the regions have to intervene, so that we are going to solve everything that I didn't mention, but that you all know: the inequality, the lack of valid information, something that we suffered from a long time, and also incoherent acting between very close regions, or the populism that we saw. And now, to finish, I would like to remember a couple of things. It is true that many regions already cooperate in an invisible way. Many of them also deal with supra-autonomic affairs, and we have to keep strengthening this political and law basis. The preparation of the national health system is an example of the changes that we have to do. It is necessary, these political changes, to better strengthen the decisions and the implementation of these decisions. Of course, we have to strengthen the preparation of agreements, its implementation, and also its follow-up. This is not a matter of management. It is a very highly political matter. It is to control the devastation of the pandemic and also its strategies. So this is a very important topic in terms of social and economic affairs, and it is very important for mental health. So we have the opportunity to act for the ruin of the populist rhetoric with institutions and instruments that promote justice, efficiency, life, and health. Thank you so much for your attention.
Muchas gracias, doctor Porta.
Thank you very much, Dr.
Doy la
Porta.
palabra a
And now I will give the
profesora
floor
Laura Díez
to
Hueso,
Professor Laura
que es
Díez Bueso.
catedrática de Derecho Constitucional
She is
de la
professor
Universidad de
of
Barcelona,
constitutional law in the
catedrática, por lo tanto,
Barcelona
del tema del
University. She is
Secretario
also a
de Leyes
colleague, and
Internacionales
currently she is
Constitucionales
General
de la
Director of
Coordinación
Constitutional
Jurídica
Affairs
del
and Legal
Secretario de la
Coordination
Presidencia.
at the
Cuando
Ministry
quiera, por
of the
favor,
Presidency.
unos 20
So
minutos
whenever
tiene.
you want, Laura, you have the floor for 20 minutes. Thank you very much, all of you, for being here with us. And of course, thank you also very much for inviting me to this session. I had the occasion to talk about with José Tudela and also Xavier Arbós, who is my colleague at the University of Barcelona. And for me, this topic that we are dealing with today is very important because it is an approximation to the pandemic that, from my point of view, is something that we have to consider given the time that we are facing now. So I will continue with everything that Michael Porter said because I agree with him and share with him some of the critics that have been made with regard to how the pandemic has been managed and also what the policy response was to the pandemic in some matters related to collective health and not only mental health of the Spanish population in this case. And as I say, also talking about more general terms of collective health. I must say that right a year ago, when the state of alarm was declared, by that time, different decisions were taken that clearly were going to have an impact in public and mental health. What happened was that at that time, because of different circumstances, as we can all understand, these decisions were not considered, how they will have an impact in public and mental health. And now we are seeing that afterwards, some months later, after the declaration of the state alarm in March last year, by that time, those consequences were not considered. From my point of view, there were two decisions that clearly had an impact, an immediate impact, I would say, in mental health and collective health. Those two decisions were the next ones. First, the rights that were going to be restricted and which was going to be the scope. And the second decision that was taken was what institution was going to have a decision on these limitations, the state or the regions, the autonomical communities. I think that both these decisions had an impact in collective health. I will begin with the first decision. What rights had to be limited and the scope of this limitation. 1 year ago, when we had to draw up for the very first time this alarm state, something was very clear everywhere. It was the need to avoid as much as possible the interaction between people. And that's why it was very clear that we had to limit the movement freedom. It is clear that this confinement, not the best on a legal basis, it is not very accurate, but we have called it home lockdown. And it was clear that this lockdown was going to have two very clear consequences on mental collective health and public health. On the one hand, a clear limitation of people relationships on the outside and with society, and also the intensity of relationships within families and the household. So here we could see collective problems because they had to think again of the relationships of the members who shared a same household and also address situations with a very high risk in terms of intra-family violence that were also taken into account when this regulation was made afterward and linked to this alarm state. Although this lockdown is probably the clearest limitation of the rights, and this had an impact in collective mental health, we were also worried about two other specific rights. At the time that this first alarm state was approved, we have talked a lot about them. The first was religious freedom, the limitation to religious freedom of many people, of course, who have different religions. And the second group of rights is strongly linked to accompanying people who were dying. And here I am referring to services when people died. With this, I would like to say that with this limitation of the rights and public health and mental health, we don't only have to focus on the freedom of movement. And also, we don't also have to focus on the intensity, but also on other rights. For example, religious freedom, going to services when people died, because they also had an impact in this collective health. Because at that time, 1 year ago, those consequences were not that considered as they should have been, given the circumstances that we all had at that time, because there were more than 1,000 people dying every day.
Therefore, a first block of decisions considering which rights would be limited and to what extent, and they had a direct impact on the collective psychological health on the first state of alarm last March. From my point of view, there was a second decision that affected collective health. That is to say, as I anticipated, who decides, which instance, which authority decides, would be decided on the restriction of rights. So they decided that the general administration of the state, the Council of Ministers, would be in charge of deciding on the limitations. Why do I consider this decision was important from the point of view of collective health? My opinion is the closer the authority is to the citizens, the more possibility you will have to cater for the needs of collective health, subsidiarity. So they chose that the governing body and the authority decided on this restriction of rights would be the state, the Council of Ministers, an authority, an instance that was far away from citizens. The problem is that we lacked precedent about how to manage a pandemic. So they decided the best would be, the most suitable would be to centralize all decisions on the Spanish state, because there was a clear homogeneity in as regards decisions on the pandemic for all towns, cities, etc. in Spain. So there was a first state of alarm declared last March. A set of decisions were taken that, well, that affected many rights taken from the state, and they had a clear repercussion on collective health. So little after that declaration of the state of alarm a year ago, the government of the nation, the Spanish government had to face the first problems linked to the incidents or to the impact of the decisions that were made in mid-March 2020. So several hindrances, several problems appeared on accompanying dead people with funerals, burials, also being unable to exercise religious rights. And we detected weeks after the declaration of the alarm state, certain groups suffered more from their psychological health. Obviously, minors, under schoolgoers, elderly people living on their own at home or in residences, in in homes, people with autism and other mental health or illnesses or disabilities. So several decisions had a direct impact on collective health. So in order to palliate, to give a solution to the emerging problems, were faced as there were adjournments. This state of alarm was prolonged by fortnights. Every 15 days, they modified those decrees so as to extend that state of alarm for 2 weeks. And I'm fully aware, and this is true, I am not excusing the state. I am trying to clarify the scenario, the status quo at that time. So the solutions given by the state government were adopted as an one-off solutions for certain groups, for instance, people or citizens with autism, without solid scientific studies that underpinned those decisions. At that time, they lacked scientific evidence. The most obvious case was that of people underage, schoolgoers. They were considering how to, provide them with the right to education. At that time, that everybody thought that youngsters were the group that tended to contagious more. So a new bill was approved, and it was highly criticized. Later on, it was modified. But at that time, they were acting to the best of their knowledge, considering the information given by pediatrics, by specialists. Last year, this Supreme Court approved or gave a decision analyzing this order, restrictions to the movement of children. So for us, for legal experts, they considered the limitations imposed to youngsters, to children and youngsters, and the openness, the measures approved to improve their psychological health were in line with the law system. So I just wanted to give this example for you to know, or so as to clarify how the government try to tackle this problem, and how we are addressing, evaluating, and assessing those measures, those decisions taking, maybe in a rush way, in a little bit in a rush. But now that we have much more evidence, and with the benefit of hindsight, we can evaluate and assess those decisions. So they try to open the mind, to be more flexible, so as to say, in terms of restriction of rights to certain groups. I gave the example of children, schoolgoers, and on the other hand, and on this, when trying to tackle problems provoked or caused by the state of alarm, They tried to, in the process of coming out of lockdown, even the state, the Spanish government wouldn't be the only authority to decide. On the other hand, they opened up and they gave competencies and powers to the autonomous communities, to the different regions of provinces, so that they could decide on how, well, to organize this alleviation of restrictions. So limiting rights less and less to this escalation, and to trying to impose restrictions by the authority that is closest to the citizens. What happened, or what happens now? What's the situation now, nearly 1 year after the first state of alert? So maybe regulations, legal regulations didn't consider the collective health of citizens not so much a year ago, whereas now things are getting back to normal. Of course, there is a long way to walk. There are still many things to do. I'm the first one to say that. We still need, there is room for improvement, but we are following the right path. Public institutions, not only the state and the national government, but also regional governments, local administrations need to realize about the impact of right limitations and restrictions on the collective health. I think that both the national government and the regional authorities, regional governments, are very aware of the repercussion of the impacts of those decisions on the everyday lives of citizens. Now, they have imposed a clear flexibility, for instance, in freedom of movement. They decide to restrict more or less according to the current situation of the epidemic and according to other options. As Mr. Porta suggested before, they don't only affect mental health, but also things that are related to the economy that in a way also affect public health of citizens. This repercussion, they tend to consider more the repercussions of the measures taken on the collective health, because local and regional governments are closer. They take the leading role in the decision-making process regarding restriction of rights as a consequence of the pandemic. And finally, and I will finish my intervention with this aspect, I think it's quite relevant and I just wanted to mention it. Some months ago, there was a proposal not only by the Spanish government, but also European governments too. They suggested the possibility to go back to strict lockdown, as was the case 1 year ago. This is a personal opinion. I must admit, the decision taken by the Spanish government and also the regional and the European governments, they decided to avoid the reproduction of severe lockdown, just to avoid those serious problems that citizens had to suffer, especially regarding psychological health. EU regulations and Spanish regulations, well, made some progress, and I would like to share them with you. In terms of the EU, they spoke about the so-called in Belgium and in Holland, that is stable, couples, they can see each other whenever there is a lockdown. Despite the lockdown, they can see each other and share time, and because they are partners. So these are specific situations and exceptions. So strict confinement or lockdown tends to be alleviated or reduced. Professor, the chairperson is telling me I have to finish, to conclude. There was a concept that was used by the Spanish government, the concept of relative or person that is, well, the loved ones. They mentioned the loved ones without making express reference to relatives, family members. Secondly, the royal decree in the Community of Madrid, the royal decree that regulates the possibility of having meetings in private space. It states that people can only meet in their own homes, and it imposes restrictions or alleviates restrictions for people living on their own or for couples that live in different places. So they have the possibility to meet, for instance, over the weekend so that they can spend time together. So these are alleviations. And also, and the family bubble, so to say, includes the family members, the people, the 2, 3, 4 people living in the same house, and also the carers that are absolutely necessary to prevent the serious consequences of social isolation. And then this is an extended bubble, so to say, that can include all those people that live together and have a direct and stable contact. So the primary bubble and extended bubble. So those were the examples I wanted to give, and I insist to conclude on the idea that there is room for improvement, but we have made a lot of progress in terms of regulations within the Spanish state. So of course we are very aware about the effects of those regulations on collective health. Thank you. I give the floor now to Professor Ms. Encarnación Carmona. She's a professor at the Alcalá de Henares University, and she is a full professor of constitutional law and a specialist on social rights. I beg you to restrict your intervention to 20 minutes, to the time allotted to each of the speakers. Can you hear me? Thank you. And see me? First of all, I would like to thank the Manuel Giménez Abad Foundation for inviting me to take part in this prestigious seminar. Whenever I read any news, any piece of news, I always read them with attention because they tackle really interesting topics. In this case, in collaboration with the Canadian Embassy to Spain, I would like to thank expressly to the other panelists, because that gave me the opportunity to learn a lot about Canada. So thanks to the 2 professors coming from this country. In the following 20 minutes, I would like to take into account that many of the attendants are not legal experts. They are not specialists in law. Of course, my background is a legal one, but I'll try to be as clear as possible. The intervention by Professor Laura Díaz-Bueso gave us a first-hand approach and perspective about how the government, the Spanish government, took into account the regulations and how they took into account the possible consequences direct consequences on citizens. So that will be a good complement. My intervention is divided in 4 different aspects. Firstly, I would very briefly speak about how democratic states cater for or try to face serious problems, exceptional situations, conditions such as a pandemic, a big natural catastrophe, lack of supply of first need products, or even wars, bellic situations due to internal or external threats. Secondly, Spain, which are the legal instruments are available to Spain. In particular, I will speak about a legal mechanism that is the state of alarm, this declaration of alarm state. That's a legal instrument or mechanism. I will briefly make reference to the 4 decrees that were approved during the pandemic, and I will finish with a brief conclusion about whether I consider it adequate or appropriate or not. First of all, about the international context, the international covenants that were ratified by Spain foresee the possibility to suspend, to conclude, or to limit rights on the face of specific conditions. The article number 4 or article 15 of the European Agreement on Human Rights, they foresee the possibility to suspend fundamental rights. The reason is to face a serious exceptional situation the state has to face, and they lack the necessary means with ordinary regulations in Spain. And this, I come to the second point of my overview. This exceptionary right is regulated by the Constitution. Not all constitutions include such regulations. To give you an example, in the different states of the European Union, there are 17 countries that foresee such a mechanism, and this is shown in Articles 51 and 116 of the Spanish Constitution. They consider 3 types of exceptionality: state of alarm, exception, and siege. There is an organic law or bill that develops those mechanisms, Law 4-1984, one that regulates the possibility to face an external crisis through 2 main mechanisms or instruments: to strengthen the executive power, giving more power to the executive, to the government, and to limit, secondly, to limit fundamental rights. Under no circumstances they can suspend the functioning, the workings of the parliament, the government, etc., etc. So the parliament has to approve these exceptional conditions. And of course, there is also judicial surveillance, control by the judges, by the judiciary, and to consider if there are any infractions. So these measures are, of course, transient, provisional, and the very moment that the crisis is overcome, they cease to apply, and they need to be proportional to the scope of the crisis, needless to say. So this state of alarm is forcing to lack of supply of food. This is the less strict, the most lenient one. Is declared by the government for a fortnight, and it can be prolonged by the parliament. They only limit rights, but they do not disappear completely. And all this is very well defined on an organic bill from 1981. Liberty of movement, liberty to propriety, to establish business, and to work. The other two types of mechanism, a state of exception and a state of siege, they are much stricter. The first one is forcing for riots and really serious alteration of everyday life, and the last one is forcing for threats to the existence of the state, that is wars. This is declared by the parliament with absolute majority. Interestingly enough, is the type of rights that can be cancelled or withdrawn in these last 2 mechanisms, not limited, but cancelled. So the organic law about suspension, about canceling rights, withdrawing rights, and not limiting rights, which is a difference. So for a certain amount of time, these rights, it seems that they don't exist. So in the state of exception and state of siege, affect rights that are the pillars, the fundamentals of a rule of law, that is personal right and safety, inviolability of your own home, secret of communications, liberty of movement and residence, freedom of expression, right to strike, etc. So in the state of alarm, exception and siege are more important rights that are cancelled. So we declared the first one, a state of alarm, the most lenient one. The organic law states that rights can be limited but not suspended or cancelled. What is the main difference between limitation and suspension of rights? Professor Villalón established this difference in a book in 1984. He said that limitation doesn't affect the essential content of the right, whereas suspension of cancellation of right can affect the essential content of a right. However, this is not so easy to frame in all instances. And in any case, what is the essential content of a right, for instance, on the prohibition of legal arrest is clear, but not so clear in other cases. This was accepted by the Spanish Constitutional Court in a decision regarding a case in 2018 when there was a strike of air controllers. So it's not so easy to clearly establish a distinction between limitation and suspension of cancellation. The most important difference lies in the taxonomy, the type of rights that can be limited, restricted, or suspended. Good. Thirdly, I will briefly make reference to the forced royal decrees approved during the pandemic. Of course, it was mentioned by Professor de Albueso. So I will start to follow a chronological order. 14th of March, that was the first decree approved for 15 days, and it was prolonged 6 times. The main objective was the protection to the right of life and physical integrity and the right to protect the health of citizens. So limitation of rights were weighted or ponderated or balanced with the protection of the right to health and life. So this decree foresees limitations of rights that were foreseen in the Organic Law 14-81, liberty, freedom of movement. I mean, there was a lockdown, so people couldn't get out from home. So home lockdown. They weren't limited. They were nearly suspended. And also the limiting private property and also right to work with the possibility to establish compulsory disposition and freedom of business.
But also this decree established some limitations that were not established in this organic law, such as, for example, the limitation to religious freedom because religious ceremonies were prohibited. Also freedom of expression, in this case because of the possibility that public powers would force some media organizations to insert some messages. The right to education because all educational activities were cancelled on all levels. And this was a very important measure. And also the right to guardianship because the deadlines for judicial matters were also cancelled. And although this was not established in the royal decree, there was a de facto prohibition of other rights that were not considered. For example, the right to vote, because there were some extensions in elections, also some protests, for example, at the 1st of May that was going to be celebrated in cause, and this was prohibited in order to protect health. Also, the right to protect data. We also talked about this. I don't know if it was Professor Régis or Professor Manuel, I cannot recall, about this limitation of this right, because an app was created that would allow geolocalization. But I have to say, in Spain, this didn't have much success. And finally, the right to equity and non-age, because during the lockdown, there were some specific cases, and people who were older than 80 years old had more limitations, and this was an age discrimination. So those were the limitations of the first royal decree 463/2020. We saw other decrees. 900/2020 in October that was applied to some towns in Madrid because of the great incidents in this region. And also the living out of these towns was prohibited. And now the royal decree that we are currently now, it is the 926 from 2020. This one lasted 15 days, and afterwards it was authorized to have an extension of 6 months until the 9th of May 2021. In this case, and Professor Díaz-Bueso also talked about this, the measures tried to be more accurate. That is to say, once we knew more about how the virus is spread, we saw that the extreme measures that were first implemented were not the right ones in this case. So now we see the limitation of movement between regions and also the gathering of people who do not live together. And this is also in a framework of co-governance. It was possible that in each region there was a different situation. And that's why the government decided to have a specific authority in each region in order to decide and to what extent they were going to implement these measures in the real decree, something that could be criticized. For example, as Professor Porter was saying before, it was the idea of this royal decree. And here, the measures are not that serious. Here we see the limitation of movement, especially in night hours, because it was proved that in night hours, there was a big number of infection, and that's the curfew, as we call it. Also, the limitation to enter and leave these towns in the region, and also the impossibility to gatherings of big people and big numbers in public and private spaces. We also have other limitations in terms of right to work and the possibility of the prohibition to celebrate gatherings when the security distance is not guaranteed. Finally, the current Royal Decree 956 from November, where there was an extension of 6 months. This was an object of debate and criticism because until now it was understood that the extension had to be of 15 days, and the government had a very difficult time to obtain these extensions, and that's why the government decided to have this 6-month extension. In this case, what they do is to strengthen, for example, some gatherings from the Ministry of Health and also the President. This was the legal reality, and to finish, I will make a brief reflection on if this state of alarm is right to tackle this pandemic. There was some criticism, especially with the very first state of alarm. And firstly, it was said that since the limitation was so intense, it should have been the state of exception. Some political parties, like Vox, for example, which is from the extreme right, said this, and they even applied for an appeal. But in my opinion, this didn't make much sense because we did not see the elements that allow to declare that exception state. we did not see these elements. What we saw, however, was the pandemic, and this is a legitimization for the state of alarm. Also, there was no suspension of the main rights, the ones that can be suspended in a state of alarm. And secondly, another criticism that was done was that after the first weeks, it was not necessary to declare the state of alarm. With the general laws of public health and security was enough. But in my opinion, this is not right, because the general law of public health do not provide for the possibility to put people in lockdown, only the people with the virus. So I think that the general law of public health were not enough to adopt the necessary measures. And some studies and reports also prove this from the legal state of law. And I think that the state of alarm is a greater guarantee that these exceptional powers that are given to the executive power are limited in time, and they will always require the authorization from the parliament. And we can also see this in international organizations. This state of alarm or exception is more adequate to tackle realities such as this pandemic. So this is all from my side, and I remain at your entire disposal in case there are some questions. Thank you very much for your intervention. Now we have finished with the talks. I am very grateful for these talks, and I am sorry for telling you this to stick to the time. And now I would like to know if we have some time for the Q&A. Yes, yes, we have time, Xavier. Okay, then we have the possibility to have questions either from the Q&A or from the chat. So please, if you could ask some questions, we will address them.
Bueno, mientras van entrando,
Well,
tal vez
in the meantime, I see that Dr. Porter raised his hand. In that case, go ahead, please. No, I just would like to say I feel very grateful for the role of lawyers and legal experts that were here today, for example, the professors that were here today. And I think that the world of law has made a very difficult job, in part because of the politicization. And that's why I wanted to mention it. And also because of the weak institutions that I mentioned. I am aware that many times, I wouldn't know how to do it. Many times we lack dialogue on an institutional and academic level between the world of the law and also institutions in order to find this balance that can be found in these topics. Okay, very well, thank you. I don't know if any of the speakers would like to say something. If that's not the case, sorry, Pepe, go ahead. Yes. I just would like to say that for me, the intervention from Dr. Porter was really interesting, and I would like to claim two of the ideas that he mentioned. On the one hand, the institutionalization, the need to strengthen our institutions, and also that these institutions have the necessary means to give a response to crisis, because many times we thought this wouldn't be possible. We never thought of something like this, but this happened, and this can happen in the future. So institutions have proved that they are weak under normal circumstances, and when they suffer from this stress, then it is a problem. And the second idea, and please, if I'm wrong, correct me, it is the need to modernize the institutions and that they are up to date with the circumstances. And here I miss this structural deficit because I think that from 2-3 decades ago, we haven't faced this need. And I wanted to mention a topic that is highly important for me, and it is our deficit in terms of administration. We have a very obsolete administration that has not had a reform in the public function, and this had an impact in our capacity to give a response to this crisis. It is stiff and inflexible. Okay, thank you very much. And now I see that we have 2-3 questions. I will now give the floor to Dr. Porta. I don't know if you would like to reply. No, I just would like to say thank you, Jose, for your comments. And we have to insist on the ignorance that we have on such complex topics. And I would say that what we cannot do is to minimize what is currently happening, because what else can happen? This is something very serious in terms of economy, social matters, suffering, mental health. What else do we need so that the society acts? And perhaps, well, this is something I have already done, but we also have to emphasize the extraordinary response from some institutions. That was extraordinary. The hospital that I am seeing from my window, Hospital del Mar in Barcelona, also had a response, an extraordinary response, because they had investments and very professional experts. And other policies, for example, public health, did not have such investments. And in those cases, these deficits that you were mentioning, Jose, we saw the economical impact, and this should worry even the right parties, because the state in this case has a very, very big deficit. And this decapitalization of administration that you mentioned, I completely agree. I follow what Carlos Ramió wrote about this obsolete administration due to the lack of modern authorities here in Spain. Thank you very much. Now I would like to compile the questions that were asked so that the speakers can answer. First of all, it is a question by an author whom I do not identify, and it is about the decision that family members could not be with the patients who suffered from COVID-19. From which institutions these decisions were made, were taken, and what were the bioethics principles? And this is on one side. And we have another question from Ángel Fernández Pérez. He asks what consequences there could be on health, a reaction from a huge group of population who are against the vaccine. And we also have a comment here about telemedicine. It is from Manuel González. It is about telemedicine in Canada. It is regulated, incorporating all the aspects related to health assistance and the protection against the electronic formats and digital confidentiality and data protection. Or if this regulation of medicine in Canada is fragmented in under specific laws. I will repeat this question again. It is about telemedicine in Canada, whether there is a general law that regulates all the aspects related to health assistance, or whether aspects such as protection data, confidentiality are fragmented under specific laws. So I will leave these questions, the fact of being there with people with bad prognosis, how we can react towards a very significant opposition of population against the vaccine, and also the regulation of telemedicine in Canada. I don't know who would like to answer from the speakers. I invite any of the Canadian professors, either Régis or Bernheim, to answer. Okay, I see Régis raising her hand. Okay, go ahead, please.
Okay, so hi again. You can hear me, I hope, because I have some technical problems with my computer, and I apologize for the slides. It was going on my computer, but I heard that it was frozen for you, so really sorry about that. So a few comments regarding the questions that were asked. I just want to mention that I'm very sensitive to the issue of, and we had the same in Canada, of patients having COVID and even really leading to their death at some point, and not being able to see their families. So to me, this is something that was very dramatic. And right at the beginning of this measure, I was wondering if that would be kind of the first case that was going to go in court, right? Not being able to see your family at the end of your life. And then the question will be, were there any measures that could have been taken to ensure security of other residents in long-term care facilities, for instance, while still allowing people to see their families? So I wonder what would be that test, and whether it would be positive or not for the government. But this is something I was really concerned about. About the other point on the institutions and the necessity to really invest and solidify our institutions. I mentioned at the beginning of my talk that public health really was the weak spot. We have many weak spots in our healthcare system, but public health, whether it is really within or outside the system, was underfunded and really neglected for a long time. One thing that we know now with this crisis, the COVID-19 crisis, is nobody will seriously say that public health is not important anymore and doesn't deserve further funding and further investment in many ways, whether at human resources level and so on. So I think that public health will rise and shine after this crisis, and we will have to find a better balance between curative and preventive care, which is something a lot of scholars, including myself, have been saying for a long time. We really need to rethink that balance of curative and preventive care. Regarding the telehealth questions, so this is, again, very Canadian, but there are a lot of different regulations that cover that healthcare services. So some aspect will fall under privacy laws or protection of personal data laws. Other ones regarding the financing of this healthcare modality will fall under provincial law, for instance, the loi sur la santé et services sociaux. So, and also the professional in itself, like the physicians, for instance, or the medical doctor, I think you say in Europe, will still have to answer to his professional order. So it will be covered with its own regulation, self-regulation related to his professional order. So it's kind of a mixed match of different regulations that kind of make this even more complicated to regulate, but that's very Canadian, I would say. Thank you.
Gracias. No sé si alguno de ustedes quiere contestar.
Thank you. I don't know if any of you would like to answer with regards to the decision of not allowing being there with family members with bad prognosis, how this was decided, or maybe with regards to the issue of possible prevention of the reaction to the people who are against the vaccines. The most specific question was where exactly, in which institution it was decided the fact that family members would not be able to be there with patients with bad prognosis. This was decided by bioethical committees. This was a decision of hospitals, or how did it work? I don't know if you can hear me. I don't have my camera on. Well, specifically, this decision, or at least in Spain, was made on a general basis. The fact of not being able to be there with the family members. It was not a matter of good or bad prognosis. And these kind of decisions were taken what we considered, which was considered by the Ministry of Health. And we saw, of course, experts, bioethical committees, etc. Apart from that, I cannot be very accurate on this because this was not a legal decision in terms of regulation. And as I say, on a general basis, the criteria was from the Ministry of Health, which decided for these general terms with patients based on the experts. Thank you very much. I will now give the floor to Raquel.
No,
No, sorry. This is a question for Professor Carmona from Martin Alvarado, whether he considers that this extension to the declaration for 6 months is somehow disproportionate, is excessive, and whether it fits within the constitutional framework. Would you like to answer to that, to reply? Yes, of course. It is true that in order to regulate the state of alarm, both the Constitution and the organic law didn't foresee the extension of the state of alarm, neither of them. Whereas other regulations stated 30 days maximum. So they made a quite literal interpretation of this bill that contradicted the practice that had been followed up to that moment. Then they had approved extensions by fortnights, 15 days. But finally, they decided that as it was so complicated to regulate and to tackle all the emerging problems, they decided to extend it for 30 days. And this is a personal opinion, but some political parties, well, didn't face the difficulties as expected from them. They didn't behave as was expected from them, and they should have supported the government and in that serious situation. And in some cases, it was really difficult for the government, for the parliament, to approve those extensions because political parties were putting hurdles, obstacles on the way of the government. And within a systematic interpretation, it wouldn't be proportional as the attendant, as the person that asked the question implies. So literally speaking, nothing is said within the constitutional text, but there would be a contradiction if we were too systematic. in my opinion, is that we needed those 6 months, as it was demonstrated by the curve, the pandemic curve. Apart from that, considering how we faced the state of the alarm in Spain, there was exclusive presence of the government, whereas the parliament should have played or could have played a more prominent role, not only by approving decisions, by approving extensions, but also the organic law says that the parliament can approve modifications of measures. Everything was approved by the government. The parliament didn't do anything, didn't have any job, any work to do in terms of modifications, and that is the authority that represents popular sovereignty. And my opinion is that they should have behaved differently. And by what I see on the news, some political parties weren't prepared to face the challenge. They weren't ready, and they misbehaved, in my opinion. They should have backed and shouldered the government in these important times. Thank you. A technical issue. Professor Bergheim is saying that she's having difficulties in hearing because apparently she hears English and Spanish at the same time. I don't know whether Professor Régis is having the same problems. Professor Bergheim, did you solve this problem?
Yeah, it's better now. Yeah.
It's already solved?
Yeah.
Yeah.
Thank you.
Can you take part now? Thanks. Great. Thank you. So, maybe Professor Bergheim can answer to this question. Raquel asked whether in Canada you have organized or made up healthcare systems for special attention to nursing homes, whether you made up specially appointed teams, healthcare teams, to cater for the needs of the most vulnerable, that is the elderly living in nursing homes.
Of course we have, but because of the lack of professional, and because we had to put a lot of professional out of that kind of houses to put them in hospital to treat COVID-19, they have not enough person to be able to treat and to put new person in group houses, in fact. So the number of places for patients are less and less important. And it's why, too, they can't have visits or outings because they don't have enough person, it means nurses or the professionals to supervise the visits or the outings. So yes, we have that kind of services, but it's not easily accessible because we don't have enough houses and enough nurses and professionals. I hope it's answering the question.
Creo que podría ser
yes, thank you, Professor Bernheim. Last question and a comment that has just turned up in English. Whether they say the following: do we have the possibility of creating? What about the possibility of setting up a public mental health services across institutions such as universities for those who need it, that is professors, faculty members, students, making those services accessible to specific groups, not generally speaking for the whole population, but for instance, for universities?
You mean for students or for?
No, la pregunta se refiere para estudiantes.
The question is, yes, for faculty members, that is staff, administrative staff, teaching staff, professors, and also students at universities.
Bueno, no sé, yo creo que esto, por dar una respuesta que por...
Hi.
Sorry, I'll give you my own. Yeah, go on, Professor Régis.
just to answer that question, so regarding universities specifically, there were services implemented, or they were already there, but amplified to really support the academic community, whether it is teachers, employees, or students. So, but these initiatives are really local, like each university would decide what kind of services they would implement. So at University of Montreal, we did that, maybe not to the full extent of the problem, because there's a lot of demand. We made also surveys to better understand the impact that the COVID-19 had or still has on the university community, but there's a lot to come, right? We know we only have a partial picture of the full impact this crisis has on that community. But just to mention that this is really local initiative. It's not the government that would say to universities what they could or should do. But I think you will need to invest a lot of resources to support the community, especially the students who are deeply affected by this crisis, for sure.
If I can add something, it's just that kind of services, because there are so much demand, they can't offer something on the long term. So they can have really therapy. They can have like emergency interventions, like 10 sessions with a psychologist or something like that. But they can have something on the long term, like on 2 or 3 years if they need it.
Pues muy bien, yo creo que...
Well, thank you. I would like to thank all the speakers for replying to the many questions. So with this, we will conclude the Q&A session. I thank the panelists for their contributions, and obviously to all the attendants, to the members of the audience. So without further ado, I give the floor back to the representative of the Manuel Giménez Abad Foundation. Maybe he will be willing to officially close this seminar. Yes, of course, I'm grateful to all speakers, sincerely to the panelists for abiding to the time given, obviously to Xavier, to our chairperson that has a great deal of intuition. And I very much look forward to seeing you again physically, and at least we will have to be happy to see each other on the screen and remotely. And I thank you, my special thanks to the Canadian Embassy to Spain, and to the ambassador, and to Marisa Cales for all the hard work she has done, and for these fruitful collaborations. Thank you, all of you, and I'll see you in the coming events. Bye bye. See you.